So welcome back to the FKB Physio Podcast. I'm here today with Saba. So Saba is a pelvic floor physio in Brisbane, like me. She has her own business as well. So Circle of Life Physio, which is in West End and now Stafford Heights as well. Actually went to uni with Saba, and we've reconnected in the last few years. So welcome to the podcast, Saba.
Thank you so much. Thanks for inviting me and the lovely introduction.
So I'm curious, like as I just said, we both went to UQ about 15 years ago now. And I'm interested to hear how you ended up where you are now with your business, etc., and in doing pelvic floor stuff specifically, pelvic health.
Look, after I graduated, I actually started off in private practice and was doing maybe 50-50. So worked at Studio Pilates as a physio there, as well as private practice. And then after several years, I realized that I had my own bunch of pelvic health issues, undiagnosed endometriosis. So I actually wanted to help myself. So I started going to courses and learning more, and then from there, I started seeing women with pelvic health issues. I got my own diagnosis of endo finally, and yeah, I love it. It's something that I can relate to. So when I see patients with the struggles of endometriosis or pelvic health issues, the barriers of I can't exercise, I don't want to move, I don't want to do anything. Am I going to hurt myself? I'm like, look, I get it. So that's sort of a long story short of how I got here.
Yeah. Okay. And yeah, I suppose when I'm thinking of pelvic health, I guess I always just think about pelvic floor dysfunction because of working with people lifting weights. That's the thing I hear about the most. And I guess as someone who I don't have, luckily, I don't have any sort of pelvic health issues myself. I completely forget sometimes that there's actually so much more to it, like endometriosis and so many other things that I probably haven't even thought about. So the focus of this episode is going to be about pelvic floor dysfunction, but you've just made me think that maybe in future we should do another one about some of those other things.
Yeah, for
Um,
sure.
yeah, so I wanted to talk about pelvic floor because, as I said, we do a lot of lifting weights with our clients at FKB Physio, and of course, most of our clients are women. And it's just such a common thing that someone mentions something to do with pelvic floor dysfunction, a sort of whole host of different things. Like it might be that they just mention that they have to go to the toilet before they deadlift, or that they need to wear like the period undies or whatever it is if they're doing deadlifting, or they've noticed new symptoms, etc. Like it just comes up a lot.
Mm,
And I guess being told different things. So I really wanted to do a podcast episode that I could refer them to. Um, so the first thing, just really basic, because this came up with someone recently. What is the pelvic floor actually?
yeah, look, great question. In terms of the ladies you see, or men as well, it is quite common. More than 50% of women, especially in Australia, but I'm sure the stats are up there all around the world, have some kind of pelvic health issue. The thing is, it's embarrassing, so they don't want to talk about it. So things like this where health professionals like you and I are coming together is just so empowering for women, because if we can say, look, we understand what's going on, we'll support you through that, they just feel so much more confident. Um, Now, in terms of what the pelvic floor actually is, it's a group of muscles. So, muscles, ligaments, connective tissue, and it sits at the base of your pelvis. So, if you imagine a hammock, it goes from sort of pubic bone, so the bone at the hard bone at the front of your pelvis, to the tailbone, so the hard bone at the back of your pelvis, the one where most of us kind of slouch and sit on. Um, it wraps from there, and then it goes out to the sides of your pelvis as well, and it's internal as well. Its main job is to support those pelvic organs. So for females, for example, the bladder, the bowel, the uterus, it supports and lifts those organs. It controls bladder and bowel movements and sexual function, as well as being one of the core stability muscles.
Okay, yeah, I mean that's such a comprehensive answer. Because I think sometimes having a vision of what it actually is really helpful. And I suppose I often also forget that it's not just muscles, it's connective tissues as well. So that's a good
Yeah.
reminder. So what are the symptoms of having a dysfunction of the pelvic floor?
So some of the common issues, if someone has pelvic floor dysfunction, is bladder issues. So they might have high frequency. So the normal is anywhere from sort of 1 to 5 or 1 to 7-ish times a day. Some of these ladies or men are going, around 8 to 20 times a day to empty their bladder. They have an urgency where they feel like, oh, I'm going to explode if I don't go. And that doesn't always mean their bladder is completely full. So that urgency can be happening even with small volumes of liquid inside their bladder. Sometimes they can have incontinence with that as well, urinary incontinence. They might have incomplete emptying. So they might get up and then 2 minutes later be like, oh, I have to go back to the toilet because they haven't fully emptied. And that can be a pelvic floor tightness issue, or it could be other things as well. But if we're talking about pelvic floor, it could be the pelvic floor is just not letting go enough. And pain and burning with emptying the bladder as well. So there's some of the common symptoms. With the bowel, that's another indicator. So I always ask about the bowel. So are they constipated? Are they straining? So some people are constipated, chronic constipation, don't even realize it. So things like sitting on the toilet for more than 5 minutes, repetitive straining, feeling of bloating, fullness, back pain, pelvic pain, all of those things can be indicators of constipation as well. And the other issue with the pelvic floor is some people have fecal incontinence. So we've got urine incontinence, but pelvic floor we know wraps around the back passage as well. So some people have, for whatever reason, they can have fecal, number 2 incontinence. Then the other one is prolapse. So if someone has a pelvic organ prolapse, so all our organs, just like everything else in our body, they move. It's completely normal. But if someone is feeling heaviness, dragging, bulging around their lower tummy or something, they feel like something's actually coming outside of their vagina or anus, that can be a prolapse. If they've got some pain around those areas or incontinence, they can be indicators of prolapse and pelvic floor dysfunction as well. And then finally, the really big one that I see a lot of is pain and sexual dysfunction. So anyone who's got pain with intercourse and, putting tampons in, their clothes touching their, their genitals being painful and things like that, back pain, hip pain. So areas that we often think, oh, it's just musculoskeletal, that there can be indicators of pelvic floor issues or bigger systemic issues like endometriosis.
Wow, yeah, and again, like there's so many things I hadn't thought of there. So that's so interesting and helpful. And I just think it's so important to talk about it because even me as a physio, I'm thinking, oh, I wouldn't have thought of considering some of those things, like say with the back pain, I wouldn't have thought, I basically have never asked someone about like their bowel function unless I'm checking for a nerve compression of the
Mm,
lumbar spine. I've only asked it as a screening question to rule out something serious. I have never thought of it as potentially, yeah, part of a bigger picture. So I think it's great to have that clear description. And again, I
yeah.
suppose some of those things indicate like overactive pelvic floor, but I think so often we're only thinking about underactive. I know for me anyway,
Mm,
or like
yeah.
dysfunctional leaking way as opposed to so overactive that it's causing pain, I guess. I just hadn't have never think about it as much as you probably do.
Yeah, look, we see both. Like a strong pelvic floor is a good thing. I actually make that very clear. It's like someone coming and going, lifting weights with you, and they've got strong glutes, and you are trying to like constantly focus on relaxing those glutes. Like it's tight for a reason. So a tight pelvic floor isn't always a bad thing. So if it's not causing problems or dysfunction, we kind of leave it alone. And we
Yeah.
we tell people, look, that's actually a really good thing. You've got a nice, strong pelvic floor. Everyone's body is different. Some people are a bit tighter, some people are not so tight. But if it's causing a dysfunction, that's where we say, okay, let's look at strategies to help that pelvic floor relax a little bit more while you keep it, nice and strong as well. The other thing with constipation, it can be a red flag for bowel cancer. So if someone's not getting better with constipation, I always involve the doctor anyway, but it's another, urgency wise. I'll go, oh, you better check in with your GP. You've had this constipation for a while. We've talked about strategies to manage it and it's not going away. So maybe you need further screening like a colonoscopy or something like that.
Yeah, and again, that's super valuable, especially because I know that bowel cancer rates in Australia are on the rise, especially in young people. So, yes, that's
Yeah.
all, yeah, very, very worthwhile information. And I think such a balanced answer as well, like to sort of say, oh, you could be tight, but it's not a problem. I love that. I feel like that's exactly how I practice as well. That like even though you see something that might fit a descriptor of like tight or whatever, if it's not causing them dysfunction, just leave it. I
Get
love
alone.
that.
Yeah, yeah.
So who is most at risk of having these sorts of issues?
So the top risk factor is actually chronic constipation. So
Oh,
the ladies who come and see me, I go on and on about the bowels because it's that repetitive straining over the years that, it's a little bit like childbirth, that constant bearing down, pushing down. It puts them at risk of pelvic floor dysfunction and pelvic floor pain and things like that. The other one is childbirth and pregnancy, the natural load of carrying a child for 9 months. And then regardless of mode of delivery, it's still a lot of recovery, scarring, inflammation around the pelvis. So often these women, it's not that they're going to have lifelong pelvic floor problems. It's just like anything. You have knee surgery, a couple of weeks later, at least a couple of weeks later, you go and see a physio and they guide you through rehab and return to movement and return to function. It's exactly the same. If someone's given birth, I don't understand why it's not protocol. Just go see your pelvic floor physio at least at 6 weeks. Get a full body screening and return to normal function. So they're at really high risk because sometimes what happens is that they're discharged, they go, yeah, at 6 weeks, you can return to exercise, you can return to intercourse, and they just go from doing nothing to doing like running or something like that. So it's not that women can't run or return to weights, it's just taking those baby steps to build up. So it's a graded load, similar to, I guess, some of the principles of weightlifting as well that you talk about. And strength training, it's gradual. It's a gradual build up for that, and you individualize it for that person and their body. So yeah, the risk factors: constipation, pregnancy, menopause, because of all the changes with the hormones, it can put a lot of stress on the pelvic floor. Aging, just the natural process of aging. Not that I treat men with pelvic health. I still see men in general, but not a lot with pelvic health, but prostate surgery as well. And then neurological disorders where they might not have sensation around their pelvic floor, or their pelvic floor is really too active because of their neurological condition. Anyone who's had abdominal or pelvic surgery or traumas like big falls or big motor vehicle accidents, or any sexual trauma as well, they're at risk. The last one is what I was mentioning before, anyone with endometriosis. So with endometriosis being a whole body disease, it does affect everything really, but it can really, really affect that pelvic floor. And the common trend is the tightness, but it's not always the case where we need to loosen or relax those muscles, but it is common with endo.
Okay. And so if someone is experiencing these symptoms or, they're listening to this and they're thinking, oh, that sounds like me, um, what should they do? I mean, the answer is going to be that they should consult a pelvic floor physio, right?
Yeah, it just makes sense. I mean, there is a lot of good information out there online and things like that. But people do have to be a bit careful following influencers and their advice. Make sure they're actually a pelvic floor physio, or at least a physio or a GP or something like that. But pelvic floor physio, GP. So I always like to have the GP involved because they're the center person. And then if things aren't improving, then I often write a report back to the GP, and they may need a referral for a urogyne or a urologist or a colorectal or a gynecologist. So it's sort of, start pelvic floor physio, GP as well at the same time, and then if required, specialists. And then the big one is they need to make some lifestyle changes. So if they want to start today without having to see a pelvic floor physio, look at your bowels. Are you sitting on the toilet for more than 5 minutes? A lot of the men have this problem. Is it actually constipation or another phone? Gross. So are you actually sitting because you're straining for more than 5 minutes? Are you going to the toilet at least every second day or so? Do you feel constantly full and bloated, and in pain around your pelvis? These are some things to be like, oh, I could have a bowel issue. Okay, maybe start increasing your fiber just a little bit by bit. Exercise helps the bowels. Managing weight, looking at managing coughing, like if you're chronically coughing or blowing your nose, it's a lot of downward pressure. So managing things like asthma, if you're a smoker, looking at strategies of reducing or quitting smoking. So there are things you can get started on straight away before even seeing a pelvic floor physio.
And yeah, so helpful again. So if they do see a pelvic health physio, um, or I was actually going to ask, what are the manage like what types of things might you do to manage it? But I also wanted to bring up what do they expect at the appointment? So what happens there?
That's a really good question because it's a little bit of a foreign area of physio. So a lot of people sort of don't really know what to expect. So I actually make it very clear, even on the phone when they're booking in, what to expect. So the appointment generally goes for about an hour and we screen the whole body. So we screen the bladder, the bowel, we ask questions that give us an idea of the dysfunction. We do a quick screening of the musculoskeletal system. Do you have jaw pain? Do you have pelvic pain, back pain, things like that? And then we sort of run through the assessment options. So, we say, okay, this is, I think this is going on, A, B, and C. We can offer you a vaginal exam, which is an internal one finger exam where we might just have a look and see where the pain is, check their coordination. Can they squeeze? Can they relax their pelvic floor? But some people, not a lot, some people go, look, I'm not comfortable with that, which is fair. So we offer them an external exam where we might just separate their labia and have a look at their strength from the outside, check if they've got any signs of infection, just light touch on the outside. And if they're not comfortable with that, then we just go with their history and just general function and things like that. Then we get started pretty quickly with some treatment in that first session. So that might include hands-on treatment. It could be desensitization techniques. It can be loosening up around their glutes and back if that's been tight. And then just teaching them how to get started with movement. So I always say, just start with something you like. Like you don't have to tick all the boxes straight away. Just start step by step. What do you like doing? You like walking, you like lifting weights, you like Pilates. Doesn't matter. Just start with something and then we look at baby steps to doing more and more, and knowing that, we know what the recommendations are and what they need to do, but building that trust so they can go, okay, we'll start with something. Then we get them started also with lifestyle things, things that they can start doing straight away. If estrogen's the issue, say menopause, then we can, write a letter to their GP. Maybe they need some topical estrogen and suddenly their pelvic floor and their bladder issues are a lot happier. Stool softeners. So that's more looking at medical management now. And then surgical management is, the last resort. So that's where we might write a letter to their GP and specialists and say, we've tried everything. And that's usually after a few months of trying everything, because most people come and see us and go, I don't want surgery. So yeah, they're the sort of things to expect. And then follow-ups are usually within a week or two to check in on how everything's going. So we don't release everyone. Like if someone's got a tight pelvic floor, it could be tight for a reason. So it's individual, but once we get through that assessment, we sort of have an idea of where to go from there.
And I guess like in terms of specific pelvic floor stuff, like might it be that the person is given like self-release techniques, or they might need a trainer? Like I know I've heard of it's like a trainer and they have to do different intensities. You probably know what I'm talking
Yeah,
about.
yeah.
Like
It's
sort of
there's so many
Oh
there's
yeah.
so many devices out there now, which is really cool because then they don't need to see us as often. So things like a dilator. So someone who's got pain, for example, like vaginismus, where they've got that pain at the entrance of their vagina, they can't even put a tampon in, their clothes can't even touch that area, or they can't have intercourse. So they can buy a dilator online, and we give them links to where they can order it from. And it's just this really soft, non-threatening device that's tiny, and then they build the size up. There's things like the PeriFit. So if someone's working on their strength and needs some feedback and they're going, I don't know if what I'm doing, it's a device that goes inside the vagina. And it's actually linked to an app on their phone, which is very cool. And it's a game. So they sort of squeeze their pelvic floor, they relax their pelvic floor, they do it quickly and slowly. So it gives them that nice little bit of fun feedback, because let's face it, pelvic floor exercise can get quite boring.
Yeah, but are they often like necessary?
It
pelvic
just
floor exercise?
depends again, like
Oh, yeah.
if someone's lifting weights or doing things like bridging and other exercises, chances are they're using their pelvic floor. So if someone comes back to me and go, oh, I didn't do my Kegels. I'm like, did you go to the gym? Did you lift? I'm like, cool, you tick that box, Often I cue
Yeah.
people, brace your pelvic floor as you're lifting. So it's not absolutely necessary. It's not everything, because a lot of pelvic floor dysfunction management is just working on constipation, working on their bladder issues and things like that.
Okay, yeah, that's super interesting. I like definitely wasn't fully aware of that side of things. Um, so then that kind of brings me to my next question, which is, I suppose the people we work with are often doing hard, like lifting or jumping, and they might have been told specifically to avoid certain things like the leg press or whatever. Um, and so should people avoid, like say if you do the leg press and you feel, I suppose if anyone has a loss of continence doing something, that's probably an indicator that their pelvic floor is not coping and they shouldn't do it, or like what do you think?
Yeah, look, it's definitely not a one size fits all answer, because it's so individual. There's this concept of athletic incontinence coming out now. And what they're saying is, and this, like if you hit a bone hard enough, it will break. So they're saying if you are doing something like CrossFit, you are putting enough downward load, it is sort of within normal to have a little bit of leaking. So I don't catastrophize it. I'm not like, oh my God, you've got pelvic floor dysfunction. If they're continent the rest of the day, when they cough, sneeze, it's not affecting anything else. They don't have pelvic pain or constipation. I just let them know that, sometimes when you are heavy lifting or um, doing certain exercises, there might be a little bit of leaking. It's a controversial topic, actually, but there is an element of normal, and we've got to weigh up the pros and cons of that activity they're doing, rather than disabling women and saying, don't lift, don't do this. There's things like pessaries they can wear. So a support pessary for someone, for example, who's got pelvic organ prolapse, where their organs are descending or they've got incontinence. There's a device I can insert inside, and it actually lifts and supports those prolapsing organs so that they can run, they can lift weights, and most of them are a little bit more continent while they do those. So I would never say to every woman, don't lift, don't jump, but sometimes we just question, okay, why is this happening? We might ask those questions, how are your bowels? Do you have pain down there? Because sometimes the incontinence will go away if we address those things. So I might give them modifications. So if someone's going, oh, I really want to go to that boot camp or my weightlifting class, but I'm really scared I'm going to make things worse, I'll just say, okay, here are a few modifications. Doesn't mean you can't jump or squat or things like that. Like, let's look at ways to keep you going, so you're getting all those other benefits, but without, putting as much pressure on your pelvic floor.
Yeah, definitely. And I think that's so important that there are ways to modify it. And I think even if, I suppose like leg press is a common one or squats, but just reducing the range of movement I found can mean that the symptoms are
Yeah,
less on.
definitely.
And I suppose like, do you think, well, sometimes people do say, I just need to use the bathroom before I do the lift, but then they're fine. I
Yeah,
guess, I guess that indicates that there might be some dysfunction there because they have to think about it at all. But if that's
yeah,
like the strategy they're using means that they can do the
yeah.
lift, I guess I always sort of thought as well that if you're doing a lift and you're remaining continent, yeah, like absolutely a huge amount of force is going on the pelvic floor. It's got to be strengthening it. It's
Mm.
got to be like, beneficial for it
Of
because it
course,
has,
yeah.
yeah. But it's
That's right.
interesting, like,
And it's like, if going to the toilet before they're lifting weights is keeping them continent, like why not? Why not let them? If someone's going to the toilet too frequently and I'm trying to get them to cut down a little bit, I wouldn't do it at the gym. I would do it in a safe space at home. I'd say, okay, you're going to hold off from going to the toilet at home. So if they have a bit of leakage, they're at home. It's comfortable, it's safe. But if they're going, for example, if they're about to leave the house to go to the shops, or they're at the gym and they're about to lift weights, I would never say don't go to the toilet. But you're right. It's like in your head, you go, okay, there could be some dysfunction. And then you might prompt them and go, oh, look, is this happening? Do you feel like you're going to the toilet a lot? So you might just check and just acknowledge it. But I wouldn't worry and try and change what they're doing. It's working for them.
Yeah, and I think you're right. Like I just say, everyone's so different, and I know what you mean about athletic incontinence. Like in powerlifting, it's definitely a thing that these women might be able to do, or every single thing completely fine. But if they do a 1 rep max effort deadlift in a competition, there's a degree of incontinence there, and I can sort of see how exactly what you said. The force is just so much. I can see
Mm.
how that might not be like inherently a problem if everything else is sort of going well. But I guess on the other side of it, I know there are also people that like every lift, even if it's a warm up and it's light, like they're having incontinence on every single lift. I think in that case, then it might be more like actually, it might not be a great idea to be doing that at the minute if you can't stay
Yeah,
continent. Like you should see a pelvic floor physio and then we'll choose a different
yeah,
exercise. My patients fit
definitely. And also
that.
seeing how much it bothers them. There's some people who are like, I don't care, I'll just wear a pad. And others who are like, well, I'm worried I'm going to make things worse. And what else can I do? Is this a problem? So you kind of gauge, based on that as well, individual.
Yeah. And so I guess, yeah, I remember doing a pelvic floor course years ago where they kind of implied that if you did lift and incontinence happened, that you were damaging the soft tissues, not the muscles, but the connective tissues. You were like stretching them out more every time you did something like that. Is that outdated advice?
I think so, honestly, because how long are they lifting? Like maybe 30, 40 minutes versus life, like chronic constipation, lifting groceries.
That's
There's
exactly.
way more pressure with day-to-day things, lifting their child, like a mum who's postnatal lifting their child who's a growing child. So I feel like that's way more pressure on their connective tissue, that repetitive kind of pressure rather than a session 1 to 2 times a week of lifting weights.
Oh, that is exactly what I think. So I'm actually so glad to hear you say that. I think it makes so much sense because, and even like 40 minutes, but they're not lifting weight for 40 minutes, like, and they might be sitting and doing bench press. The actual amount of time that they're lifting weight for is so short. I've thought that exact thing. Like, this can't be so much more strain on the pelvic floor than everything else. So,
No.
yes, I'm very glad. So I just had one more question, which is that sometimes, so all of that sort of conversation, I guess, feels like it applies to people that have pelvic floor dysfunction some way or another. But I guess the other side of it is people that have had a surgical repair, say of a prolapse. And I have met a number of them that have been told that they have a lifting restriction of 5 kilos forever. And so, I've met women in their 40s who have been told that they're not allowed to lift more than 5 kilos ever. And if they do, they'll damage their repair and like that's it. They can't get another one, which is like very scary for everybody involved. And I have always just stuck to it because I thought, well, I don't want to cause any damage there. But is there some like wiggle room there? I would never try myself, but if they were sent to someone like you, is it
Mm.
true? Only 5 kilos forever?
No, it's not realistic. Like it just goes back to function again. It's like some of these women are told not to squat ever again. It's like, well, are you going to tell them not to sit on a chair ever again? Like it's just not practical. So I think what's missing with some of these specialists, they're doing an amazing job. They're going in there, the surgery's complicated, like full respect, but they don't have that continuity of care like we do. So often they go in for a follow-up and then that's it. They might say, I'll see you in 6 months or see you in a year, come back if there's a problem. But they see us. And often what these specialists say, because they're not really seeing them often, it could be just that they're so busy, that they've got to give a very broad kind of safe answer. So these are probably questions women are asking. And so they're giving a very safe answer, don't lift more than 5 kilos and don't squat. The reality is most things take about 3 months to heal. So yes, of course you do need to be a little bit careful in those first 3 months, just like someone who's given birth and things like that, or had any surgery, back surgery, knee surgery. First 3 months is, you're a little bit more cautious, you're letting things heal a bit more, but it doesn't mean they can't lift at all and that they can't lift more than 5 kilos forever. If they're progressing gradually, it's that graded return to lift. If their symptoms are okay as they go, and there's no reason why you can't build them back up to lifting, barbells, 20 kilos and things like that. You can make modifications, their legs, rather than be doing wider legged squats and things like that. You can go a little bit more narrow. Like you said, the depth, you can modify the depth as well so that they can still lift heavy, get those bone density benefits and strength benefits, but still being mindful of those problems. And it is tricky when they're coming to see you with that strict, no, I can't lift more than 5 kilos. It is really tricky. There's more pressure on the pelvic floor. Can't remember the exact weights, but there's actually a lot more pressure on the pelvic floor just sitting on that machine where you're doing like
Oh
crunches
yeah.
than lifting weights. So they're not saying don't do that. They're saying don't lift more than 5 kilos and don't squat. It doesn't make sense.
Yeah, and I remember when I looked this up and tried to find if there was research to support it, and there wasn't really, but there was some studies that showed that coughing and laughing were really high pelvic floor load comparative to, again, I can't really remember the specifics either, but it was like squatting with a certain weight and those sort of things. And it was, those day-to-day things produced way more force.
Yeah,
I just know that, yeah, it is really tricky with those people because if anything was to go wrong, they will be pinning it on the weightlifting because that was the thing they were told not to.
yes.
So, yes, it's very tricky to navigate, and I guess it depends on the person too and what they're comfortable with, but it's good to know that it's probably not as black and white as it's been presented.
Yeah, definitely. And like sometimes you can even ask them to get a second opinion from another specialist. Just say, look, I think, you can go see a pelvic floor physio, see what they think. If you're still worried, maybe go see another specialist and get a second opinion because like, of course, if they've done surgical repairs and things are stitched to, certain bones around the pelvis and it's all healing, we do want it to form some healthy healing without too much downward pressure. But that heals after a few months. So the idea is once it's healed, the surgery's helped their symptoms, that they should be able to just get on with normal life.
Yeah. Wow. Okay. Well, that is so helpful. Everything you've talked about is so good. Is there anything else that you want to mention that you haven't yet, or do you feel like we've covered a good base of what to think about when you're thinking about pelvic health?
Yeah, I think we've covered most of it. I just want women to know that, if you've got pelvic health issues, don't be scared to lift. There's amazing physios out there like Frances who specialize in lifting that I send my patients to. She will support you through a graded program. So it's not all doom and gloom if you have pelvic health issues. And just know that most women will have some kind of pelvic health issue at some part of their lifespan. So you could be young and in your 20s and you might have pelvic pain or incontinence. Just know you're not alone and it's very treatable. Even though these issues are common, it's very treatable. But don't let it be a barrier to lifting and doing the things you love.
Awesome. Thank you so much, Saba. And again, it's Circle of Life Physio on Instagram and based in Brisbane. So if you do have any pelvic health concerns, Saba and her team are the people to see for sure.